Great. Well, welcome to another season of A Dose of Dizzy. We're actually starting season 3. Super excited. We've taken a little bit of a break. It's been a busy spring, but we're excited to get up and going. I don't think we've talked about our third season yet. I don't know.
No,
It's been a
no, not too much. There's a lot of new ground, I think, being covered this season. One, I mean, which is probably obvious now, is we're sort of incorporating this video recording throughout the season. So hopefully this goes well, but we're excited to bring you all, a whole new batch of all things vestibular. So Liz, I guess you can, do the honors and
yeah.
introduce our first guest for this episode.
Yeah, so this whole season, we are planning on having guest interviews. It's going to be I'm excited to learn and be able to talk with the major movers in the vestibular field and hopefully serve as a motivation. I know we have quite a few students who listen to the podcast, so hopefully serving as a motivation to stay involved with clinical research in any way, even if it's just reading it. So our first guest we are so excited about. It's Dr. Jamie Bogle from Mayo Clinic in Arizona. She's actually the division chair, I think is the correct term, of audiology. And most people that I talk to have heard of Jamie, and I feel like I talk about her all the time because I had the pleasure of studying at Mayo my 4th year as an externship and learned a lot of really amazing things. And one thing I definitely appreciated from both like the clinician and the researcher side is just how like calm, cool, and collected she is with patients, and she takes things methodological with everything from patient care to looking at research or new ideas. So we're really excited to talk to her today, and thank you for being here.
Well, of course, thank you for inviting me, and thank you for that nice introduction. It's perfect.
Yeah, thank you so much. So I guess we could just start off. Jamie, just talk to us a little bit about, your background, how you kind of got into this field, and, what led you to where you are today?
Sure. I think like probably most of us, I started out in communication sciences at St. Louis University. I was fortunate to be able to learn from Maureen Valente during her time there, and she's, as you know, a really wonderful, fantastic vestibularly focused audiologist, although I didn't know that at the time. I knew she was an audiologist. And so, within my class, there were, of course, like, the black sheep that were going into audiology. And it was a really interesting time because that was really when the AuD was coming into to our field as an option. So when I graduated, I had no idea what this AuD was going to be, what we were going to do with it. And I actually chose to pursue a clinical PhD with Christy Yoshinage Tano at the University of Colorado in Boulder with a focus in pediatrics. So I wanted to be a peds CI person, which is completely not what I do at all, ever. But I did quite a bit of work looking at progressive and late onset hearing loss and language outcomes and all kinds of things that you would probably never suspect I would do. But I think really with the progressive hearing loss, some of the syndromes associated with progression really also started tapping into the vestibular system as well. So when you think about large vestibular aqueduct, Pendred syndrome, all of these. And so I was starting to get exposed to it there. And, I was fortunate to be in Colorado at the time when Steve Ackley came out on sabbatical from Gallaudet. He was being threatened with taking the chair position. And so instead of that, he decided to take a year off and head out to Colorado and avoid that, which I can fully appreciate. And so he was the first one who really started working with me in vestib. And I was tasked to be a research assistant with him and one of our visiting physicians who were working on this new VEMP response and trying to set it up in the clinic, and how are we going to do this, and how are we going to measure it appropriately. And so that's really where I got drug into it. All through my 4th year, I didn't think I was going to do this at all. The STIB was not my thing. But I think being able to work with somebody as awesome as Steve was really helpful in moving me into that path. From there, I was able to kind of merge everything. Christy was not exactly pleased by my decision to transition into some vestibular work. And so we compromised, and I did a bit of work looking at pediatric vestibular assessment for cochlear implant patients. So she's actually, if you talk to her now, is the biggest advocate for pediatric vestibular testing, but it was a little questionable for a couple of years. So right. It's not what I signed up for. But throughout that time, I've just been fortunate enough to kind of just run into people at the right time, and was able to launch a postdoc just because I met Dave Zappala at a AAA poster session, and moving into my career at Mayo. So a lot of very fortunate just meetings, and I can't thank them enough. But it does really point to, I think, some of the importance that we have as mentors to bring up the next group of educators and researchers.
So just out of curiosity, and this question comes up quite a bit from especially students, but what was your vestibular course like? And, how did you have multiple classes in it, or what was your exposure in grad school, or even just like the perception of vestibular at that time?
Yeah, so at that time, we were really excited because we were going to get an actual full class of vestibular. At the classes before mine were only doing a half of a semester. And so I think that really, it's really sad looking back on it, actually, that we did have such a limited exposure. But my class was taught by a physician, which brings on a completely different slant than a class taught by an audiologist or a clinician who's running these tests. And not for better or worse, just different. I would say my physiology was a lot better than maybe my testing skills, which is fine. That's great. I think most of us are, at least in my cohort, are self-taught in a lot of ways. And that's true probably for the groups before. And, maybe you guys too, to some degree. We don't get nearly enough education, at least in our training. And hopefully you get it in your fourth year, but even then it's still not complete. And definitely very heavily skewed towards, auditory pathways and auditory systems.
Yeah. You bring up an interesting point, because just like Liz mentioned, we do hear that quite a bit from students. What were some of the ways you had mentioned that, you were able to, your vestibular education, a lot of it was self-taught. What are some ways that you sort of brought that in, and what different avenues did you end up going down to kind of learn this complex system that we all learn?
Yeah, this is it's a lot of self-directed learning to some degree, a lot of online classes. I read a lot. Sometimes it's the cases, you get a case that comes through and you're like, I have no idea what this is. And now I do. And, so it's very much depending on what the needs are at the time. I do think now there's so much more information online, available videos, even textbooks that are available now that weren't even around at that time. It has gotten better. I think there are more people who are talking about it, and more online options for people to seek out help. But a lot of it is still very self-directed.
Yeah, that's, I think, still a general consensus. I do think the resources have increased, but it is kind of interesting. I was curious just how it was back in your day. Just kidding. It wasn't that long ago. But I mean, it changes so quickly in vestibular. I am curious, like year to year, how it's changing. And, sometimes it's based on the school too, what limitations and resources there still exist. But so transitioning, I know you said BEMS were some of your first exposure, especially like clinically and research wise. Talk to us about how your research in vestibular has evolved, and, maybe some of the highlights and what you're maybe currently working on, or has been a little bit more current for you.
Sure. Most of my work has been really focused on otolith. I find these little organs really quite fascinating, even within the training I did receive from my coursework, and even early discussions about vestibular, even just clinical testing. It's all about the VOR, and that's great, but that's not the whole picture. And so, when we were able to start evaluating these additional end organs, this was amazing. This was like the most amazing time to be a vestibular person because nothing had changed for like 100 years really before this. So to have this new technology was really amazing. Um, and so I was probably a bit brought in on that, just with that being such a novel piece. Um, but I think also it brought in some of my work and interest in electrophysiology. Also brought in some of my interest in aerospace practice and microgravity work, which was just, the fourth grader in me wanting to be an astronaut and not being tall enough, right? Um, so I have worked mostly in that area, and that really starts to straddle then the additional areas of concussion and migraine. Then of course moving into OVEMS, which again we're new and who knows what we're doing there yet, and some of the more functional pieces. So Liz, as you know, my practice is mostly neurological related, mostly migraine of some sort, and we've done quite a bit of work looking at some of the presentation in that group because there's no migraine test. So developing some sort of clinical profile to help guide our neurologists into making the right diagnosis is quite important.
Which I think arguably are in like some of the most challenging parts of vestibular. Like when you combine migraine and concussion patients, it's like a big dark hole of not patterns or not consistent patterns.
Yeah. That's the one consistent thing about it, right? They're all over the place. But it, I do think that there are some common features and things that are important for us to understand. The last bit of work that we did was looking at functional skew deviation, essentially using subjective visual vertical, and finding the terrible ability of these patients to do this simple task of orienting a line, which I think we all knew this. They all have spatial orientation issues, but to be able to document that and use that as a piece that maybe adds to that clinical marker is an important thing to add. And I think we start there, but then it's since taking that step back and saying, okay, well, why is that? What's different about our migraine population that makes this result so obvious and so unusual for them? And that, maybe that takes a few years down the line to sort out, but maybe that does help with treatment options.
Yeah, that's super interesting. Do you have any, so I know a lot of questions we tend to get are from clinicians who are either, on their own, vestibular audiologists who don't necessarily have support or can't, chat about these types of complex patients. What would be some of your like top tips or things that you've learned specifically from the migraine population on things to look for, test to add, or just like general, tips to be aware of?
Yeah, I've seen and worked with migraine patients for a very long time now, and I think one of the more important things to consider with this group is identifying what you need from that test battery. What are you looking for? What is your level of suspicion for peripheral vestibulopathy? It's quite rare in this group. It can happen, but it's not the common thing. So when you are looking at testing a patient with that suspicion of vestib migraine, what's going to be the most useful data point that you're able to collect and the most important profile that you can create? And understanding that you may not be able to do every test on every patient, and that's okay. And sometimes you don't have to do a caloric, which is the most amazing thing ever. And especially with that group, they don't have the ability to suppress that atypical motion. And so understanding that my job is to identify a reasonably normal peripheral system. And if I can identify difficulties with interpretation and perception, that's where the problem is. It's the central interpretation piece that I want to get to. And really trying to hone that down into what's most effective for that identification. I think when we think about migraine specifically, we are looking at ocular motor features, atypical otolith pathways, poor balance, poor gaze stabilization. Anything that has to integrate anywhere is likely going to be involved. And just how bad it is depends on where that patient is most likely heavily involved. I love your cat participating.
Strong appearance.
Trying to make his get his 15 seconds of fame here.
He's got way more than that. In fact. No, that is super interesting. How do you feel? So I feel like one of the challenging aspects of our field and our diagnostics is in recommendations and or referrals. So with the migraine population, do you feel like we're at a point where if you see atypical vent patterns and this and that you're able to make specific recommendations for the patient? And if so, what do they look like?
Yeah, I do. And I understand everyone works in different environments. And for me, I do have a bit more flexibility in what I say. And that I do understand. But I do think it is our responsibility, if we are working with a patient, to provide guidance to either the patient or the referring provider. After we've just spent 2 hours with this patient, I think you probably have a good handle on some of the other pieces maybe going on. So if if maybe you are the first person seeing that patient and they have a very strong suspicion of vestibular migraine, making a referral to headache neurology is not inappropriate. If you're not comfortable with that, that's okay. Send them back to their primary care with that recommendation. This patient fits the characteristics and the classification for this disorder. You might want to consider it. I do the same thing for anxiety and depression screenings. If their DHI is 96 and they're, really struggling with dealing with the dizziness, whether it's the cause or the effect, they still need to manage it. So, making that recommendation as well for mental health or psychiatry, psychology, cognitive behavioral therapy. We've been doing a lot more referrals to our integrative medicine colleagues. They're really quite capable of managing chronic disorders, particularly things like pain management, which have a lot of characteristics for some of our chronic dizzy people. So I do think we're at that point. I think we need to be at that point because we're very rarely seeing acute vestibulopathy that's just going to go away in a few weeks and rehab itself. So, we have to get out of that bucket of just referring. Maybe we refer to PT. Well, no, that's great. Let's see who else we need to rope in.
Yeah. You speak to a really great point because not only, what you're talking about just shows how multidisciplinary our field is, but how unique of a position we are as audiologists sort of direct, where this patient is going next. I think, I think it's certainly appropriate for us as vestibular audiologists to own that position. It's really quite fascinating to me. Just kind of speaking on top of, these migraine or these vestibular migraine patients, you had mentioned, making these recommendations to headache neurologists. Are there any other, professionals that you sort of bring in or any other recommendations that you make given the other, wide variety of symptoms, whether it's visual vertigo, those types of things? What sort of things can a clinician, kind of tap into beyond, referring to that neurologist to manage the headaches?
Right. No, that's really important because the reality is it's probably going to take them, 6 weeks at best to get in with a neurologist, right? So for a lot of these patients, I will start to give them some exercises. I'll try to get them working on balance, maybe some VOR exercises just to get them moving. We'll do a lot of cervical stretching, making sure that they understand what they need to be doing safely, so that the neck can start to loosen up in the process of getting them back. I think all of this is well within your scope. It's just educating yourself on how to teach that to the patient and demonstrate how to do that. A lot of our vestibular migraine patients are younger and are really struggling with family and young kids and jobs. So how do we help them manage some of those pieces? And that doesn't take any sort of, physician oversight. More so it's just what's common sense? Like the computer screen, yeah, you're going to hate it. So let's work on how do we make that more manageable so that you can work efficiently. So look, talking about filters, contrast, font size, what happens, when you bring in your 5 computer monitors and you're trying to bounce around. So we do a lot of talking with just those day-to-day strategies and what's going to keep their symptom load more tolerable until we can get the migraine managed. I think it's so important to give them something to focus on.
Can you talk a little bit? So obviously concussion is something I learned from you too, but kind of a similar realm as the migraine patients. Do you see these patients for follow-up because they are dynamic conditions? Do you find that like vestibular diagnostics is useful in like whether it's migraine, concussion, or both? And if so, how do you manage with that?
For migraine, I don't see them too terribly often coming back. It's usually, if they come back, it's usually because something has gone awry. And maybe they have new symptoms, something has changed, they went off a medication and now things are horrible. Or maybe they did have a concussion and now there's a whole host of other symptoms. For concussion, we do a lot more monitoring, and it does depend a bit on the acuity of the patient. So we do see kids, young adults very quickly, within 24 to 48 hours of injury, to get a baseline of their symptom load, as well as basic ocular motor features, balance, gaze stability, and then look to monitor them over the course of the following week, 2 weeks, 4 weeks, through recovery. Most of the time, you're going to see them maybe 2 or 3 times before things have cleared up and they're returned fully to play. For those who don't, which unfortunately does happen, then we do tend to go to more of a monthly, 3-month, 6 months sort of follow-up. The goal is to identify, of course, any sort of features that we can rehabilitate, or which pathways may still be impaired. And, when you're working with concussion, sometimes you can't fix it. And that's a really hard thing, I think, to get around. But sometimes we can't. And so just identifying, okay, well, here we have really terrible smooth pursuit, which is quite common. It's still terrible 3 years later. So what are we going to do to really help that patient manage this? Because, we're not getting any traction on that recovery, or not complete recovery. And so it is an important thing to have some of these metrics so that we can identify what's improving, what's not improving. And if we know what's working, then we can use that to scaffold and build on a rehabilitation program to really push them forward as best we can.
I think I didn't probably put this together till now, but I do think that was a big, important lesson that I learned just observing you in concussion is you're talking more like with migraine patients and concussion patients, it's beyond vestibular, just saying is it central peripheral. It's what's working, what's pathway. And I know a lot of people tend to ask about what is really the true value of like VNG in these populations, because a lot of times maybe typical VNG measures are normal in migraineurs. So why would we do it? And I think now looking at how vestibular diagnostics have advanced, and even just like how we can look differently at like, yeah, maybe something's normal, but it's causing them symptoms, or, it's still something in that pathway is disrupted. So it's,
That's right.
I like thinking that way. And it's in line with our PT colleagues that a lot of times are asking what's functioning and what's not, and how well is it functioning, and how do we get them back to a level that they want to be at.
And I also think too, I mean, even when you do these testings, yes, it may come back, objectively normal. You may, the metrics might, fall within the normal range, but just looking at it grossly, I mean, you can tell that, these ocular motor pathways, some of these central neural pathways are disrupted. Just looking at it, even if they do fall within that normal range. So certainly speaks to a lot of that value.
So I have a curveball question, which I tend to do this because like my friends are always like, where did you come up with it? But I don't know, this might put you on the edge. I'm curious, what is your like favorite research study that you've done, or that you're like most proud of, like a paper that you've published or a project that you've participated in? Or I don't know if that's hard to think of off the top.
Ooh. I would say there's one study in particular. I don't even think we ever published it, but it was the most horrendous study I've ever done in my life. And it's horrible. So I'll tell you.
It's when the world hears about.
So, we were working on a project looking at motion sensitivity, and it was very specific. It had to be in a moving vehicle with the, you know this one,
Yeah.
with the rider looking at a computer screen playing a video game, because they were trying to mimic a tank or something in the whatever. So we get this stupid Land Rover that has been modified, and with like a cage around the person in the passenger seat so that they can play their game and not get any outside information. But all of the air ventilation was going into the box. And so we had 3 examiners also in the car. We had a driver who, I don't know how, but this was one of our 4th years, who decided that she was going to drive. And we all agreed to it. So that's Sarah Carpenter.
Number
for
one.
those of you. Yes. So there's that. Part 2, Dr. Pradhan and I got relegated to the back seat, both of us with laptops to monitor EGG, which is a terrible thing to do in a car. And then the other I had the video game. And it was the most horrendous thing I've ever done in my life. We were driving around the Mayo parking lot in like giant figure 8s, driving through Scottsdale which is probably totally illegal, but trying to make the patient sick. And the only thing we succeeded in doing was making ourselves incredibly motion sick. And so it was a terrible study, but it was a lot of fun to think back on now that we're not doing it anymore.
So now you're most proud of, maybe most memorable of that.
Yeah,
Most
talk about a
Most
unique study.
I think that is such a great demonstration, though, of bringing things outside of the lab, because a lot of times I think, that generalization doesn't always happen in vestibular research. So that's like as real world as it gets.
Something like that.
It's so like everybody asks about motion sensitivity in the car. So
Absolutely true.
you'll have to do a little follow-up.
Absolutely.
Yeah, follow up on a Cessna.
Maybe.
Let's go. Let's take it to the air.
Oh,
Yeah,
geez.
2024.
Okay. So as long as I get to sit in the front, I will be all right.
Well, I guess we can. I mean, I feel like we could probably talk forever, and that's what's cool about vestibular. And anytime we get to connect, I think it's always so nice because we always learn something new, like even little nuggets of how we can clinically care for our patients better or research ideas. But just from your perspective, and obviously you have done so much for the field of vestibular, where do you see it going, or what are you most excited about right now, or where do you see big opportunities? Because a lot of students ask about research projects. So just where do you see it going?
Absolutely. What I think I'm most excited about is seeing where we go in terms of vestibular cognition and these relationships. I think that the central vestibular system is so unknown, and we have kind of some blanket ideas of how things work. But how do we test it and create better patient outcomes for these very complex patients? And I've seen this, in terms of like how we've approached, central auditory processing disorders. How do we kind of look at that model and bring that to our table and try to get at some of these concepts? I'm really excited to see that there has been some interest emerging in that, and how this relates to cognition and aging, I think will be a really important piece. On the flip side of that, I think I've been so excited to see all of the pediatric work. I was just ahead of the curve by a lot of years.
Right.
But it's really
Started it.
wonderful. It's so wonderful to see and to know that people are interested in it and will make a big difference in the lives of these kids.
Yeah.
It's a really good time to be a vestibular audiologist.
It is. And I feel like it's our field, the little mini field is growing for sure. Do you have any general advice for students who want to get involved with vestibular, or, maybe early professionals like me?
Sure. I think one of the more important things is to, to trust what you're seeing. Take that data that you're getting from that patient and wrap your head around it, because it's if something is off, what is it about that eye tracing that seems off, and explore it, because it could be a very important key piece for that patient as they're struggling through a diagnosis. I think it's important to have mentors at all stages, and people who you can send those weird tracings to help weigh in. And that doesn't go away. I still have my people that I email a lot. And it's a little satisfying when they also respond back with, I don't know, that's weird.
Good luck.
Good luck, you. But it's important, especially if you're on your own, if you're the only person in a practice that's working in this area, just to develop that network of people that you're comfortable asking questions to, and to get involved with, some of the societies that are focused in vestibular, and to meet some of those people along the way to help, because it is a small group and it's not uncommon that you are by yourself in that lab.
That's very nice. And honestly, I think that'll help put a lot of people, at ease, sort of demystifying the whole process too. It's certainly nice to know that, just from personal experience, every mentor that I've had, or every, other colleague that I've interacted with, it's a small field, but everybody is just so welcoming, and it's just been certainly, so approachable, I think. So it's so nice to know that we're in that kind of environment, especially if you're getting into it for the first time. That, of course, can seem a little daunting.
Well, thank you so much for joining us. I know we will definitely request some of your articles that you've published if you want to share with students, to be able to read up a little bit more about what you've done and how you've contributed, because I think it's one thing that we are always trying to do is encourage students and clinicians to read the research a little bit more, because once you get out of school, it's no one's keeping you accountable. So part of it is you're more likely to read if you've heard a little bit more about the person behind the paper. So we'll be sharing some of your articles of your choice with everybody. And if they have questions and stuff, we hopefully can get you connected with them.
Yep.
Awesome. Happy to.
Yeah. Any last words of wisdom for our audience?
Well, I think if you haven't spent much time in the vestibular lab, it's worth a go. I do take it as a point of pride when I can convert a fourth year over to the vestibular side of things. It's a really fascinating area, and I hope that we can get more students exposed to it earlier, so that they can make those decisions to get those good, strong fourth years and practice.
Excellent.
And hopefully contribute more research too.
Absolutely. Which we all need. Absolutely. Well, thank you so much, Dr. Bogle, and we're certainly excited to have you as our first guest, and excited for the rest of the season, for us to learn so many great things from a lot of the experts in the field. So we appreciate your time.
Instagram and Twitter will be sharing those articles, and then also just updates about our guests. And then we'll make sure to share opportunities to ask questions within there, and hopefully can get some expert answers back to you. So we'll see you next month.
Take care.
Bye.